This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 765, recorded on June 4, 2021. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Fort Lee, New Jersey, Dixon Despommier.
Hello, everybody. And it's cloudy and coolish, but that's about to change for tomorrow and the day after. So let's enjoy this while we can.
24 Celsius across the water from you, Dixon.
Yeah, not so bad.
Also joining us from Madison, New Jersey, Brienne Barker.
Hi, it's great to be here. It is pretty sunny here, actually. Also 24 Celsius. I know that's shocking. Or 75 Fahrenheit. And getting ready to be very warm this weekend.
Also joining us from Western Massachusetts, Alan Dove.
Good to be here. And it is also 24C here, 76 Fahrenheit.
Wow.
Overcast. We just had some thunderstorms roll through, and I think we're supposed to get some more.
Cool. I decided to move east to west. Also joining us from Austin, Texas, Rich Condit.
Hey, it is also 24C, 76 Fahrenheit.
No way.
It's true.
We can't believe this.
And it is overcast. We have had quite a stretch of rain, which is fine. We're over the seasonal normal. The reservoirs are filling up. Everything is just glorious.
That's it.
Cool. And I would like to wish Dixon a happy birthday. Happy birthday.
Dixon, happy birthday.
Thank you. Thank you.
Is it today,
Tomorrow.
Vincent? Tomorrow. Close enough.
Happy birthday.
Happy birthday.
I call it D-Day, but D-Day was actually June 6th. So they postponed it a day because the other D-Day was then.
Actually, so wait a minute. No, you were before the year, right?
I was. Yeah, well, way before the year. Yeah, sure.
You know who was actually born on D-Day?
No.
Phil Sharp.
Mm-hmm.
Hello.
I'm sure a lot of people were, right?
Yeah, a lot of people.
That's right.
And unfortunately, a lot of people died on D-Day.
Yes, they did. Yes, they did.
Indeed. Anyway, it's D-cubed day, really, Dixon.
D-cubed today. That's right. All right.
Now,
take that.
you're 61, right?
Yep. You betcha. No,
Yeah.
I'm 81 years old and feeling every year of it.
Happens, yeah.
It does.
You look great, Dixon.
I feel
And it's
good. No,
Great to be here with you.
Thank you. Thank you.
It's our
Say the
privilege
feeling
to
is
be here.
mutual, entirely mutual.
I hope we can do this another 20 years with us.
Wouldn't that be lovely?
I hope I can. Yeah,
I don't think you could stand me at that point. I really don't
we
think.
can.
I couldn't even stand me, probably.
It's all good. It's all good. All right, we have a little potpourri of COVID-19 for you today. Tuesdays are becoming non-COVID and Fridays are COVID. It's not a fixed in stone, but that's just the way it's turned out. So I want to talk about a few things and get the thoughts of our esteemed panel here, and they are esteemed. The first is that, oh boy, the WHO has decided to rename the SARS-CoV-2 variants.
Right. Oh, I'm so glad. I never learned the other ones.
Yeah, right. All right, so I have to say, I think this is pretty weird, but they basically now have given them Greek letters, where, so for example, the former B117 lineage, it's a lineage now, it's not a single virus.
That's true.
It's called Alpha. B1.351, which originated in South Africa, is called Beta. The P1 from Brazil is called Gamma. The B1.617.2 from India is Delta, and so forth. And my first reaction is completely uninformative, although the original one wasn't very informative either.
Right.
Which means maybe we should have tried for something more informative. And I mean, if you say the Alpha variant, really, you think I'm going to know what the heck it is? Anyway, what do you guys think? Do you have any thoughts on this? Do you care or not care?
We'll just say, what's it all about, Alpha?
I guess I guess probably the most important thing for me is that I don't care a whole bunch. Okay.
Okay.
Not and it doesn't make any difference whether I care or not, because nobody's going to listen to me. All right. We're going to get to some comments from somebody that I largely agree with. There's no way I could remember. I was kind of sort of getting used to the Pango lineage. I guess that's what it's called. I was only vaguely aware of these other names. I understand that people don't want it named after the place of origin, but frankly, that's the easiest way to remember them because they are familiar terms. You don't have to learn something new. And my other last comment is that I do notice that the alpha, beta, gamma, delta represents the sequence in which they were identified or tagged as something of concern. So that may help a little in remembering what they are.
I think if any of those strains was more lethal, I would remember that one. But all of the others, I agree with Rich. I think it's just, scientific gobbledygook.
I think they might be easier for me to remember if they were the first names I'd heard for each of these variants. So instead of the British variant being first called the British variant, and then me having to keep relearning names, if someone just said this one's called Alpha, I would know it now as Alpha. Although I also remember our conversation with Robert Gary recently, where he talked about the A and the B lineages and that early split to A and B, and I would have expected that was somehow reflected with the Alpha and Beta. And I was confused when I actually really started to look into these Greek letters and saw that wasn't what Alpha was for.
No. And so this is a political thing because of the politics of giving things place names, especially in this context. Although, of course, in virology, we have a long history of using place names for everything. And if you look at flu strains, right, variants, often variants of particular concern, are named after the place of original discovery. And in fact, the H1N1 swine flu had California in the name, right? So this is perfectly normal procedure for virology. Early on, we were referring to them that way. I have tried to keep up, like, the UK, I mean, the B117, whatever. This is a bridge too far for me. I'm not going to keep up with this. And it's got all kinds of ancillary problems to it. What happens after you get all the way through to Omega? Is the next one going to be Alpha Alpha?
Sub alpha. It's alpha sub
alpha sub 1. Are we going to go to superscripts? It's already hard enough to type SARS-CoV-2 on a phone keyboard. So just this is getting a little silly.
I would have liked the nomenclature that had Zulu in it.
Sure. Well, I mean,
to tango.
Yeah. One thing I always think of as soon as you start with alpha is like, oh, is it Bravo or Beta next?
Right.
Well, the influenza nomenclature uses origin, and no one has a problem with that. So I don't get this. You have, for example, A. If it's A, B, or C, you have A, then you have slash the place of origin, California. Then there's slash isolate number or lineage number. Then you have the year, 2009. And then in parentheses, you have the subtype, H1N1. Man, that tells you everything you need to know.
Yeah, I think this may change as we get more and more of these variants and people just wear out of, okay, so what if you call it, London, or you call it Cape Town, or you call it Houston, or whatever, wherever it happens to have been isolated, because that's what's happened with flu. Nobody cares about the place names because there are so many place names. It's not like anybody's dominating it.
Well, the one thing I was talking to students about right when this all started was that when we think about the UK variant, in some ways that naming is a positive thing for the UK because it actually tells us they were doing sequencing.
Yes. Yes.
Yeah, no problem. All right, so my one of my favorite Greek persons, Theodora Hatziouanou,
Who has two relevant areas of expertise on this.
That's
She's
right.
a virologist and she's Greek.
Right. So
That's right.
I heard through the grapevine that she was ranting about this on Twitter. So I asked her, would you care to share your thoughts with us on TWiV? She said, you bet. Okay, so here are 6 points. 1, naming viruses after places has been a long practice, as I am certain all virologists are aware. It is actually useful because it indicates origin of the outbreak, easier to remember both for scientists and the public. I cannot for the life of me remember what amino acid substitutions are associated with any of the numbers in the current variants, I suppose. All right, number 2. Why are scientists crying outrage when Wuhan HU1 is the official name of the original virus in all scientific papers? Yeah, well, that's another thing. 3, Greek letters are already being used in the ICTV nomenclature of viruses, including for coronaviruses. So will we end up with beta coronavirus SARS-CoV-2 beta variant? Yeah.
Yes, that's what we've got.
Good point. Apparently, the committee did not think of this. You know, I heard the committee, they said, hey, we were pretty unanimous on this nomenclature. What were you taking, guys and gals? Come on, it's not useful at all.
It was 10 minutes before lunch and they had to go.
Number 4, the first 4 to 5 letters of the Greek alphabet are easy for probably most people, but it can quickly get confusing. For example, I doubt that people would be able to tell the difference when pronouncing the Greek E-N-Y, epsilon, and ypsilon.
Right. From Ypsilanti.
5, I won't even go into pronunciation of Greek letters by foreigners.
Yes, in fact, to make her point, Vincent just talked about epsilon and ypsilon. I learned them as epsilon and oupsilon.
Oops.
Oops.
And number 6, you can always find something to be offended by, and people that want to find excuses to be horrible will always find them. I have a hard time believing that with all the things that are going on, this is the best use of WHO's time. I just think it wasn't necessary because it doesn't improve the situation. Like we were getting used to B.1.1.7. Okay, I got to learn what that was. And I have a cheat sheet actually on my computer that I open up whenever I'm going to talk about these things.
Actually, the one
just
thing.
Number them. Right.
The one thing that's useful about this is that the nomenclature comes with a chart that tells me all the different names and where they were first isolated so that I can know what I'm talking about.
Right.
Yeah, but I got confused over Norwalk virus, thinking it came from Norwalk, Connecticut, and it actually came from Norwalk, Ohio.
Oh, that was in the early days.
Sometimes, I never forgot that. That was a absolutely humiliating experience for a non-virologist.
People wrote in and said, "Hey, tell Dixon."
They did.
Well, if
And
somebody ever isolates a Springfield virus, it'll be everywhere.
That's right, or the Columbia virus.
Yeah.
That's true. You're absolutely right.
Every state has a Springfield, right?
Every state has a
And
Springfield.
a Washington and a Columbia and a Jefferson and a Madison and you can go right down that list.
I see no cat today, Alan.
She was actually on the desk for a little bit. And she likes to parade back and forth to get petted.
I see.
But then she got off the desk when I went to get my water, and she hasn't come back.
Come back, and of course, Brienne is in your office today, aren't we?
Oh yeah, I noticed that.
Yes, our summer research program started on Tuesday. So I am now, for the next 8 weeks, mentoring students in the lab all day.
Oh,
So no cat in your office.
No cat in my office. Although the students have asked me to change that, but I don't think it'll happen.
So if I remember, the door behind you goes to the lab, right?
It does.
And periodically people peek in to check you out.
Yes. Well, right now, because I have so many students, we've taken over a larger space. So they're only coming in and out there to get things out of the fridge or something like that.
All right.
when are they going to do their plaque assays? You can let us know, and then we'll all look in them.
I will, yes.
I want to pass along.
By the way, the cat just walked into the room, so she may.
Oh, thank you.
Cat just walked in. There's a series of videos by Hayao Miyazaki, which are quite old, before the famous ones, like Porco Rosso. You've probably seen them, Alan, because you're a fan, right?
Yes, I have not seen Porco Rosso.
But there's a couple about cats, actually, that are quite good. And they're early style, so they're quite amusing. I can't remember the names. Anyway, I have an interesting opinion from Ron Fouché about variants and transmit. Ron Fouché is, I would say, an expert on transmission of viruses.
Yeah.
Yes, we talked about his interest in transmission of influenza viruses. Anyway, he wrote, I do not think any of the SARS-CoV-2 variants is truly more transmissible nor more infectious or contagious. These are all words being used, which are probably all wrong, or at least there's no evidence for such phenotypes. For the D614G variant and later B117, aka British variant, there was evidence for efficient global spread, outcompeting prior variants, but that is not the same thing. We see this for flu all the time. Such displacements can even be the result of neutral genetic drift. For flu, as you know, this is often due to immune escape. Antigenic variants can infect a larger number of hosts, and that is enough natural selection advantage for the new variants to outcompete the older ones. And he sent me a slide deck. He gives a talk about this with the data to support it.
Right.
And you can see, he says, flu variants replace each other like SARS-CoV-2 without anyone ever talking about increased transmission. It's the host that is changing, in my opinion. And so I think it's interesting. He says, you just need a slight advantage to outcompete, but this is being interpreted as, more efficient transmission. I think, as we have discussed, it's probably fitness. And he's talking about fitness, really.
Yeah.
And in the case of flu, it's because of immune escape, or at least moderate immune escape. Anyway, I'm trying to get Ron on to talk about this in some detail.
Fitness could be lots of different things, right?
Yes. Yes,
Sure.
including transmission or antigenic escape or a lot of other things. Absolutely.
That's right.
And this, going all the way back to Darwin, in Origin of Species, he talks about how tiny an advantage can be, significant. And the issue is any slight advantage in reproduction is going to boost it every single generation. And with a virus, every single generation is happening very fast. And so, any little advantage. And so this could be any number of things. It could be immune evasion. It could be something with where it replicates in the respiratory tract. It could be anything.
Yeah, I think the point is that we don't know yet.
Yeah.
Right.
I like his point about flu.
Yes.
That flu strains replace each other all the time, and nobody ever talks about transmission.
Yeah.
That's a good way to think about it. Yeah.
So as I said, I asked him to come on and talk about it. I think he will, because he's been on TWiV a few times.
Yeah.
And he's a fan. So and we did his paper not too long ago about transmission in ferrets. Ferrets knows where the virus goes.
Yes.
Something like that.
That's right.
All right. A few more small bits of information I thought would be of broad interest. So the results of two studies suggest that the Pfizer BioNTech mRNA vaccine is highly effective against the alpha and beta variants. Guys know what that is? The alpha, of course. The
117 and the 351.
351. Yeah, that's right. So these are just worth pointing out briefly. So the let's see, the Pfizer, it was published in the Lancet. Impact and effectiveness of this is a study out of Israel, right? Of the mRNA BNT162b2 vaccine against SARS-CoV-2 infections and COVID-19 cases, hospitalizations, and death following a nationwide vaccination campaign in Israel. An observational study using national surveillance data. So they have a great reporting system in Israel, and they basically use the national surveillance data from the first 4 months of the vaccination campaign to look for cases of laboratory confirmed infections and outcomes. And the effectiveness range, this is great. It includes asymptomatic infection, symptomatic infection, hospitalization, severe or critical hospitalization, and death. Man, talk about granularity, right?
Yeah.
You get the whole thing. So during this period, January 24th to April 3rd, 232,000 infections, and hospitalizations, severe deaths, et cetera. They got them all here, and then we can get the effectiveness. The effectiveness is at 7 days or longer after the second dose, okay? Overall, 95.3% against infection, all right? Laboratory confirmed infection. 91.5% against asymptomatic infection. 97% against symptomatic. 97% against COVID-related hospitalization, 97.2 that was, 97.5 against severe or critical COVID-related hospitalization, and 96.7% against COVID-19 related death. And so that's all good. And the cool thing is 95% of these infections were caused by B.1.1.7. And this, again, is a mRNA vaccine made against the ancestral virus. Which,
yes, and I learned in this paper that the international proprietary name was tozanamarin, which I also hadn't.
For the vaccine?
Yes.
Oh.
Really?
I'm glad I didn't know that. Couldn't even pronounce it.
Yeah.
Well, I was just sort of, wondering, we have MAB and IB as things for antibodies and inhibitors.
Yeah.
I wondered if there's going to be some kind of suffix for mRNA-based therapeutics in the future.
So what's the name of the vaccine again?
So it is tozanamarin.
Now, I don't see anything related to vaccine at the end there, right?
Right, no.
In fact, none of the vaccines.
But it's got mRNA in the name.
I like Shingrix, but
yeah, that's
maybe we
Shingrix.
should put X at the end. Vaccines. Let's see. What would be the vaccinia-based vaccine, Rich? It's already got a name, right? It's
it's Dryvax.
Dryvax. Well, that's the old one.
Yeah.
Then there's ACAM 2000, then there's MVA. I know of no sort of product name. There may be one.
Vax would be a good thing. VAX, right?
Yeah.
You could hire WHO. You could hire the TWiV team to come up for a name for vaccines. Okay.
No. Drug naming is an entire specialty within.
This is true.
There's a whole bunch of interlocking constraints. You don't want it to be too similar to something that already exists. You don't want it to be confusing to doctors. You want to get. That's why all the monoclonal antibodies are MAB. So it indicates kind of the type of drug.
Yeah.
Yeah. You don't want it to be an existing car name. Or a Pokemon.
Yeah. All right. Continuing with this vaccine story. So
let me interrupt for just a second here. So I was, I'm refamiliarizing myself with the paper. I think you were reading numbers off of table 2, which is 7 days after the second dose.
Right. That's right.
There is a table 4, which is 14 days after the second dose. I think that's the only difference. And the numbers are a little better.
Yeah, not surprising.
And in the adjusted numbers, there's nothing less than 94%. And most of them are 96 to 98%. That's looking at all ages for all of the different conditions you described. This is, I continue to be stunned.
Yes. Indeed.
By how good this is.
That's true. That's true.
Yeah, I mean, the fact that they're showing here infection and not just disease and seeing this magnitude is crazy.
Yeah.
And these tables are great. And I think that this is, I'm sure it's open access. And it gives you the numbers of people that they're talking about and everything else. It's a huge study.
Yeah.
Okay.
Yes.
Yeah. And Israel was able to, I mean, you can do this in Israel because they've got a whole bunch of factors in their favor. One is that they vaccinated basically the whole population. They did it almost all or maybe all with the Pfizer vaccine. So everybody got the same shot. And they've got this great health system that can track all these data, and they've got the technology to do all the sequencing and everything.
And there have also been increasing numbers of papers that have come out recently saying that the variants are not impacted by T-cell recognition. So it doesn't surprise me to see that the variants do not change the efficacy.
Indeed. While I was looking at these data, I came across the paper of the Novavax vaccine, which we had reported, we had talked about in a preprint. It's been published in New England Journal May 5th. I thought it was worth just reminding everyone. It is it's
a subunit, right?
Yeah, that's the protein spike that Matt Freeman talked about, where the C termini of the protein attach, and they form florets and multi-spike florets, and it mixed with an adjuvant, and it seems to work pretty well. Anyway, this is a phase 1/2 trial, I guess it's phase 2A/B. Sorry, 1/2 is before. And this was in South Africa, HIV negative results. In the primary endpoints, laboratory confirmed symptomatic COVID 7 days or more after the second dose. So this is not stratified by severity like the Israeli study. And the reason this is interesting is because it's mainly B.1.351, which would be the beta variant, right? And,
yes. I have to go through
variant.
I have to go through 2 translations to get there.
Yes.
Maybe I'll get used to it.
Yes. And so the vaccine, of course, is produced against the ancestral strain. I guess it's a strain. Yes, it's the only one strain. Wuhan HU-1.
Yeah.
And the efficacy against B.1.351 was 51%. And this is, but here's the thing, as Brienne just said, we know the T cell epitopes have not changed in this. So I really want to know what was the efficacy against disease.
Yes.
Not just infection. And we don't have that here because the data are not present, right?
And also this is a phase 2.
Yes, it's smallish, right?
You have to be really leery of comparing phase 2 data to phase 3 data, because a phase 2 is not powered to give you reliable efficacy numbers.
Actually, they say in the conclusions, mild infection, sorry, I misread it. Never mind what I just said. I'll cut it out.
So, yeah, and so as a phase 2 study, this is a much smaller number of people than in the Israel study.
Yeah.
So there's one sentence in here that caught my attention, and I want to make sure that I'm reading this right or understanding this right. This is in the discussion, and it's about, to be accurate, the first sentence in the second paragraph. In this placebo-controlled vaccine trial, we found that previous infection with first-wave prototype-like pre-B1.351 viruses did not appear to reduce the risk of COVID-19 due to subsequent infection with B.1.351 variants among placebo recipients during the initial 2 months of the follow-up. So the way I read that, this is sort of an extra observation that they can make, that they can gather out of the data that's not necessarily relevant to the vaccination. But looking at the placebo group, if I read this correctly, they're saying that infection with the ancestral strain is not providing protection against infection with it would be beta strain.
But what is the readout? Is it infection? Is it mild disease?
I think it's disease, but I don't know.
See, that's important, right?
Did not appear to reduce the risk of COVID-19. The implication is, well, I don't know.
Any kind of COVID.
I take that as symptomatic. If they'd gone to the effort of looking at infection numbers, they would have said.
Okay, because the reason I brought this up is that the J&J vaccine was trialed in South Africa, and it was also reduced efficacy against COVID. However, 100% effective preventing hospitalization and death, right? Mm-hmm. And that's why I bet you would find the same here, except they didn't stratify the data.
Right.
And that's, of course, what you want. You do want to prevent the most severe.
Well, but I think the interesting point that comes out of what Rich just said is that the virus, the natural infection, didn't seem to provide protection against subsequent infection and disease with the 351.
Yes, but maybe it prevented hospitalization and death.
Hospitalization and death.
And we don't know that because we don't have the data.
And we already knew from earlier data that people were getting SARS-CoV-2 more than once. Right. Yeah. We had multiple reports of people being reinfected with apparent separate infections.
You can be infected after being vaccinated, but you typically get mild or no disease, right?
Right.
I mean, given the size of the study, they certainly weren't powered to really be able to look at
No.
that.
No. But the J&J one was a phase 3, and I'm always impressed because I heard the director of research from J&J talking about it, and he said, the antibody studies where we take serum from vaccinated patients and check it against B.1.1.351, tenfold reduced neutralization, but still the vaccination completely 100% prevented hospitalization and death. And he said, must be the T cells, right? So that's what I'm thinking here as well.
Yeah, and I mean, that's what the T cell data that's been emerging over the past couple of weeks have also said.
Mr. T will save us.
Which, of course, we have had here Alessandro Sette weeks ago to talk about this, and now the press is finally catching up, if they are. But what I see, so the reason this is interesting is because, if you're vaccinated and then or recovered from an infection and then you get infected, the antigenic distance between the virus that infects you and the virus you were vaccinated against will determine how much that virus will reproduce in you, right? And so you can imagine if the antigenic distance is great, and I don't know how much great has to be, you might get mild or even moderate disease, but you'll still be protected against severe disease because the T cells will kick in at some point. And how much the variant has to go to say, we better make a booster, I don't know. And I don't think anybody knows yet. And for influenza, they make an assumption. I think it's, a 4-fold reduction in anti-HA titer from season to season. They decide to change the vaccine because they think that correlates. And it's always a correlation. They don't know. Yeah. And we don't know that number for SARS-CoV-2. It might be different. Is that making sense to everyone?
Yep.
Yes.
I think so.
Okay. And in connection with that, the last little snippety here, Moderna released a statement indicating that early results from an ongoing study of their booster, they've made a new mRNA against B.1.351 and P.1. And then Rich found the actual medRxiv preprint of this, which is preliminary analysis of safety and immunogenicity of SARS-CoV-2 variant vaccine booster. That's from Moderna. And so they have made, as I said, B.1.351 and P1 mRNA spikes. And they've done a phase 1 basically and looked at safety and looked at immunogenicity. And so I wanted to point out this statement here. They say, in recent evidence of waning antibody levels after infection or vaccination point to the need for periodic boosting of immunity. And I think that somehow ignores the fact that antibodies always wane. Immunity, as Rhiannon said months ago, immunity always wanes after vaccination, after natural infection. You don't need to keep high levels of antibodies and T cells in your blood or even in mucosal surfaces.
It would be actually bad. It's not even that you don't need to. It would be bad if you did.
So you need to have memory, right?
Right.
And if you have low levels of antibody in blood, that usually tells you there's some memory B cell somewhere. So I don't understand this statement. It kind of forgets basic immunology 101.
They're justifying their work. They're justifying.
It's not correct, though.
Right. They're justifying continuing to work on this and developing booster shots. I mean, a better way to phrase this would be, we don't know whether we're going to need booster shots, so we're going ahead and checking it out.
I would say, we don't know how much antigenic variation we can accommodate with current vaccines. So we should, and I think it makes perfect sense to explore variant. That's fine, but isn't that quite right? And they go on to show that if you give people these mRNA vaccines, your virus titers go high.
Antibody titers,
So, for example, let me just point out, they're doing pseudovirus neutralization assays. Neutralization titers against B.1.351 and P1 after the first mRNA vaccine, the ancestral mRNA vaccine, 6 to 8 months later, were low or below the assay limit, although against the vaccinating strain remained above levels likely to be protective 6 to 8 months later. So they're waning, but they're still at good levels. But they're saying they're probably too low to neutralize 1.351 and P1 enough, although we don't know what enough was. And then they say, when we give people these new vaccines, their titers go way up, and that's fine. So essentially, these are safe and could be used if we need to. And I think what you need to do is not do neutralization assays, but look at disease, right? Reinfections in vaccinated people and see what kind of disease they're getting. That's what's going to tell you.
Yes.
Neutralization assays are not going to tell you the whole story. I mean, you could correlate the two. You'd probably want to do a neut and say, okay, we had all these people who were vaccinated. These people got asymptomatic. These people got mild and moderate. And here are the antibody levels, the neutralization levels. That would be intelligent to do, I think.
So
So-
they seem to not do here.
Mm-hmm.
They do a booster with these variant mRNAs, but they don't actually show you booster with the same.
Yeah.
Yes, they do.
Do they?
3A and B. Are you looking at the paper?
I am.
And this is what
all right.
impressed. This is what impressed me. If they boost with the original vaccine, mRNA 1273, it boosts everything. Okay, it boosts against the ancestral strain, and it boosts against both. That must be beta and gamma. Sorry, but the South American and the Brazilian strains.
Yeah.
Okay, it does not boost the beta and gamma to the same levels as the original one, but it's quite a significant boost, and we don't know what makes for protection. It is a log scale there, so there's at least a 4-fold difference, something like that. Now, the other thing they say, and then they show similar data with boosting with the variant vaccine, the equivalent to the 351 guy, and they see the same thing. Okay, that is, it boosts neutralization titers to all three viruses. Not only that, I mean, they say, maybe I'm misunderstanding this, but they say that the vaccine against the variant boosts immunity against the variant better. I guess they say better than the vaccine to the original strain. And while formally that's true, I don't know that there's a significant difference amongst those numbers. My takeaway from this, in fact, looking at the data, I'm no immunologist here, all caveats are applicable, but I see that both vaccines boost everything.
Yeah.
Okay. And frankly, I come away from this thinking, oh, well, that's good.
Yeah. The original vaccine is the booster.
Yeah. So I'm actually, I see where I got my confusion from. And since this is a preprint, if the authors are listening, the part where they talk about figure 1 in the text and boosting with either 351 or 2211 is really confusing because you don't actually do that in the paper.
Yes.
Talk about it in the text.
Yeah.
Right.
Right.
So, at some point next season, we're going to have to decide whether to move to a different spike vaccine. And by the way, this idea that it's a booster is absurd. It's not a booster. We don't call the flu vaccine every year that we make
not a
brand
booster,
new. It's
right.
not a booster. Come on. Who started saying that? Probably Tony Fauci. Whatever he says, everybody picks up and just repeats. It's not a
Let's
booster.
take it easy on Tony. He's
Yeah, he's having a
probably
rough
getting
week.
plenty of flack.
He's getting a lot of flack these days, yeah, since they released all his emails.
which show nothing.
Nothing. Except that he
it's-
doesn't listen
Why
to
would
TWiV.
it?
I saw some of the supposedly inflammatory quotes, and I was like, come
on.
what are we in a rage about here?
Actually, they show me
It's
that
a
he's
lot of emails and replies to a lot of
Yes,
They show
exactly.
me that he's incredibly hardworking, which I already knew, but
Engaged.
wow.
Yeah, he is. He
Yeah,
is.
they showed me that he doesn't listen to TWiV because he never once
He
said,
never
hey, you got to
mentioned he
listen to this
searched
TWiV
for
episode.
TWiV,
Not even the
yes.
one he was in. Okay, that's fine.
Yeah.
But it's not a booster. It's going to be a new vaccine like the flu vaccine may be revised from year to year. And when would we decide? Well, we have to see what variants are circulating in the U.S., right? If
Right.
there's very little B.1.351 beta, right, then you don't need to switch to that. Or maybe if you think if you switch to that, it's going to protect against everything. But that study has to be done.
I think what we need to do is monitor hospitalization numbers.
Yeah, that too.
Because that's the endpoint that matters. And before we go signing everybody up for an annual shot of something because, this variant is circulating and we have no idea what the significance of that variant circulating is, let's wait until we see some actual indication for it before we add this burden to the health system. And I suspect what's going to happen is that a combination of immune memory and ongoing background levels of infection are going to provide all the boost that people need. Yeah. If we get to a point where we do see hospitalizations going up, the absolute first line response should be to go around and give what would be a booster shot, the original vaccine. So find people who are high risk, give them another round of shots with the original vaccine, see if that fixes your hospitalization numbers. If it does, you're done.
Of course, if all the hospitalizations are in people who are not vaccinated, then what you need to do is
then
quite
what that
clear.
tells you is that you need to vaccinate the rest of the population.
Right.
Yes.
What I'd love to know is of the people that didn't get vaccinated, how many of them have already had it, and they just didn't want to get vaccinated because they thought they were already immune.
Yeah, Daniel on last night's clinical update, he said cases have been really low lately, but he did admit someone yesterday, 55-year-old guy who was not vaccinated.
Right.
And Daniel said, I said to him, what are you thinking? And the guy said, yeah, I know. It's my mistake. I should have gotten vaccinated.
Well, now you know.
So he said, I hope you have a very simple 5-day course,
Right.
So,
exactly.
Anyway, by the way, I went today for a COVID test because I'm having a medical procedure next week. And for the first time, they shoved it all the way up into my brain. I never had one of those before. I'm thinking, why are they doing this? The anterior nares are fine, but he pulls this long thing out with the little thing on the end. And boom, it was all I could do to stop sneezing.
Right. Right.
And then for like 10 minutes, I was like, yeah.
Wow.
Oh, gee.
But in most places, they just do the swabby thingy, right?
Yeah.
Oh, well.
At any rate, I come away from all of this optimistic, actually.
Yeah.
Sure. Okay? Absolutely.
And so I think, the first wave of vaccination is absolutely key.
Yeah.
All right. And I think that gives us a lot of wiggle room.
Yeah.
Okay. To see what's coming down the pike.
It's true.
I mean, the current... We have immunity against ancestral strains mostly, ancestral variants, the original and then some of these variants, right? I just wonder if you start immunizing with variant mRNAs, you're going to put a different pressure on. You may get different variants emerging as a consequence, right?
You could.
So I think you have to look at that before you decide en masse to switch.
But I think we also need to look at the historical or prehistorical precedents of other coronaviruses, the common cold coronaviruses, which are whatever they were in the past. They are their own vaccine now, right? They circulate in the population. Yeah. You get a little sniffle, you got the virus, you got over it. And I think that's the endpoint that we are most likely getting to with SARS-CoV-2. The vaccines are saving a lot of lives because we don't have to have the period of millions more people dying before we get to that. But then once we've got the population vaccinated, then just the virus circulating, it's going to vary, and the seasonal coronas vary, and it becomes one of the 5.
So, Alan, that's a great point that you just rose, because they aren't dying anymore. So why aren't the people who aren't vaccinated yet take note of that and say, gee, I don't want to die either. I guess I'll get vaccinated.
Yeah.
Because it's proof. I mean, it's not even science. It's just numbers. You can just see that the line is going down. Wouldn't you like to be part of that group?
Their information stream is different than ours.
Yes.
Well, sure. You don't think Fox News carried that? I think they might have. It's possible.
I don't know. To Alan's point about the seasonal coronaviruses, they are continuing to change a bit over time as well, and they're still acting as their own vaccines.
Yeah.
And the other thing that this makes me think is that it's going to be important going forward to have sequence data on, in particular, individuals, sequence data and vaccine history data, in particular on individuals who are at least those who are critically ill. Okay, if not everybody who's hospitalized. I don't know how much monitoring we can do, but the more, the better.
Right. Okay, we have a couple of papers, but we can go through these relatively quickly. But
good luck with that.
I mean, that's fine. We can chat as much as we want. I just don't want you guys to get scared that there's two papers and it's going to take another 2 hours.
I'm not scared.
Okay, good. First one addresses an issue we've talked about in kind of a formal way. It is Nature Communications, Impact of COVID-19 Outbreaks and Interventions of Influenza in China and the United States. This comes from a number of institutions in China, including the China CDC, and the last author is George Gao. And, this addresses this issue that we've mentioned in many places. You see much less influenza initially in the 2019-2020 season, but also in the current season as well. And as they say in this paper, this gives us, this was before 2019-20 reduction was before we had any pharmaceutical interventions for COVID. So it's a good opportunity to look at non-pharmaceutical interventions, right? Distancing and face masking and other kinds of shutdowns on influenza transmission, because that is really followed very carefully globally. Yep. So in China, they have an influenza-like illness sentinel surveillance system. And here in the U.S., we have one, and it's publicly available data. So they took the opportunity to go onto the website and pull the data out and analyze it. And that's what they did here. So the little history here. So before COVID was confirmed in China in January, they say influenza activity in the north and south were what you would expect for that time of year, high epidemic levels.
For a bit, high epidemic levels. It was a kind of normal to bad flu season, wintertime.
So this is January, starting January 23rd, 2020. All provinces initiated their highest level public health emergency response to COVID, and influenza activity subsequently decreased from high during week 10 in the south and in the north, much lower. And they actually have lovely graphs that show this very clearly. They have in the I guess this is the north of China and the south. Mm-hmm. They have the epidemic week from the beginning of 2020. Then they have when the coronavirus was identified, and then they have the observed influenza activity in a green line. And you have this red dotted line, the Wuhan lockdown, and then the green line crashes. The influenza cases crash.
Yeah, the cases were starting to come down a little bit, which I think was partly just the natural cycle for flu, because you get into December, January, February, you start to come down off flu season. But I think there may also have been some anticipation from people in China seeing the news out of Wuhan and saying, oh, this could be a SARS thing. Let's, be careful and wear our masks and, because that's a thing that was already a thing there. And so there's a little bit of a drop. And then, as Vincent said, January 23rd, and then it just, and
they also have on these graphs the historic influenza levels from 2011 to 2019. And you can see they would normally continue at and not really decrease until start to decrease maybe week 13. And still pretty high by week 17. But last year it was very different.
Yeah.
So are they counting hospital admits as the way of judging whether or not
this is influenza-like illness reported, I believe.
ILI.
So what reported to who?
This is just China
CDC, I think.
No, I realize that, but how did they get that data? Who is that coming from? Physicians at hospitals?
Yeah.
Or is it coming from?
Yeah, they use the system. It's very similar, I believe, to what the U.S. uses. Where
so that big sharp drop could have been the fact that nobody went to the hospital. They suffered with flu at home and still had the same amount, but they weren't recording it because they didn't get to the place where they counted.
But people with respiratory illness post-Wuhan lockdown were being detected and put in either COVID clinics or hospitals because they were being very, very stringent about that sort of thing.
I mean, the COVID...
I think you would still have seen influenza.
Yeah.
I mean, we didn't see it here, right? We didn't see any. We saw almost no influenza here.
Well, we're going to get to the U.S. data in a moment.
Yeah, no, I understand that, but
there was quite a bit, Dixon.
Okay, well,
it was even super normal for a while.
But then, right? So, yeah, we'll talk about the U.S. data in a moment.
All right, I'm sorry, I didn't mean to preempt.
Yeah, I would say that the fact that they see similar trends, say in both northern versus southern China and in multiple different places, kind of argues a little bit against that. Because you wouldn't expect sort of everyone to stop going to the doctor at exactly the same time.
Yeah.
It's a good point, though. Reporting is they didn't talk about reporting, okay, in the that I recall in the paper.
Right.
And it's an interesting point.
It is a potential issue, but my argument would be that this was, if anything, a time of hyper awareness about respiratory illness.
Yeah, because we're diagnosing COVID clearly, right?
Yeah. If people developed a cough and flu-like symptoms, they were probably going to show up to medical care to get their COVID test, or medical care was going to come to their door and give them a COVID test because in China, that's the way it was being done.
All right. So for the U.S., in the U.S., we declared a state of emergency on March 13th. Our influenza activity was high or moderate, similar to previous years, and then after that declaration of emergency, starts to decline, but it's not a crash because we really didn't take it very seriously back in March, right?
Right.
No.
Right.
Yeah. So in this, and the figure really, and these are open access, the figure, it really shows it nicely. It actually looks like we were having kind of a bad flu season. It was a little above average.
Yeah.
And then it's declining, but it's hard to say because if you look at the plot of previous averages, that's kind of March-ish, you'd see a decline normally.
Yeah.
And then in the U.S., you can't really say that the national emergency declaration was the same as the lockdown in China because it was not uniformly implemented nationwide.
No. I mean, it wasn't anywhere near the severity as in China in terms
but
of
nonetheless,
lockdown, right?
we see after that coming way down. And my understanding is if you look at the data from this past flu season, it's just down across the board.
No, I think the past
we didn't have a flu season.
Yeah, I think that's more impressive actually in the U.S. because that's really when we've not locked down, but done masking and public gatherings or
people were taking it seriously by a year later. Yeah.
So I would say this illustrates the difference in the extent to which China took it seriously and we did not on influenza activity. So it declined, but it's not really, it kind of follows the previous 8-year trend. It's just a little higher, but the decline is not really, doesn't correlate with the emergency declaration on March 13th. They seem to think it does, but I don't really think so.
Yeah.
They note that it's, they say compared to China, somewhat smaller apparent impact was seen, and they offer several explanations. One is that's phrased very nicely. Differences in implementation of COVID-19 interventions.
Yes.
Another is later arrival of COVID-19 in the U.S. so that there was a shorter overlap with the flu season. Inclusion of data from public health laboratories, which often used for influenza confirmation, may artificially increase percentage population, and this percent positive. And this is interesting. A larger portion of the U.S. population receives the influenza vaccine, thus lessening influenza to start with.
Right.
So lots of possibilities.
Yeah, I do like the fact that this primarily Chinese group of researchers did not say, because y'all are freaking idiots.
Right.
Although, it would have been maybe appropriate to include that.
So the next thing they do is to model, okay, so what if we didn't wear masks and shut down public places and distance and lockdown and all that stuff? What would have happened? This is called autoregressive integrated moving average models. And, as I said, with or without masking. So here's what they found. 59.7% of influenza-like illness cases would be prevented in 59 and 50% in southern and northern China by these interventions. That's the bottom line there.
Right.
So in their opinion, that's what's making the difference here.
Yeah, so they just extrapolated the flu season as if that had proceeded like a normal flu season, what would have happened, and then compare how much reduction there was.
Yeah, I mean, it's basically taking into account the reduction they observed, right, and applying it to an earlier flu season, right? And then they did the same thing for the U.S. numbers during the same epidemic weeks. And they would say positivity in the 3 weeks following the epidemic, week 17 decreased 67% from predicted levels. So similar approach there. And they do some experiments to validate this model. So that's basically the data. And they say that, these decreases in influenza are probably associated with implementations of non-pharmaceutical interactions, masking, eliminating mass gatherings, distancing and so forth.
Yeah.
And they say, this, if we don't have in the future, when we have outbreaks, maybe we should wear masks. Maybe we should do this.
There's a lot, obviously, that got implemented as part of these lockdowns. Previous data on flu have told us that schools are major centers of flu spread.
Yeah.
And so closing of the schools early on, I'm sure, had a big impact on flu.
Yep.
Which is not something I think we want to do every year.
So again, these include reduction in travel, physical distancing, canceling mass gatherings, and closing schools. Those are the main things. And they say, the last sentence is very interesting, it will be critically important to assess the independent and synergistic impact of specific measures on influenza, especially since some have great socioeconomic costs and may not be acceptable to the public or government for mitigating seasonal or pandemic influenza. And you read into that politics, right?
Yes.
Yeah, I mean,
so one thing I've kind of been wondering about this, and it's been something I've been wondering about, and then people have suddenly started talking about it, so I've been excited, has been how this will impact strain selection for upcoming influenza seasons. So I was part of me wondered, is the N going to be big enough for us to know which flu strains are circulating? And are we going to be more likely to miss the flu strain because we don't have enough samples? I think that most of the things I've read recently are saying that the folks who are choosing those strains are actually really happy that they think it's going to be much easier to tell which strain will dominate. And so I'm really curious to see how this changes that flu vaccine that comes out in the next year.
Yeah, it's a good point. I mean, if you go by what Fouchier said, the influenza people have their own way of thinking of things, and hopefully they're not going to be overly influenced. Because I think we just don't know for SARS-CoV-2 what all the variants mean yet, and for flu we do, right?
Yeah. And it'll also be interesting to see in places that continue some of these measures. I mean, we're never going to be the same, I think it's safe to say. And
no, not at all.
There may be some of these, obviously not closing the schools every year, but maybe reducing our number of mass gatherings in certain seasons, and maybe things like really harping on employers to provide paid sick leave. Really encouraging people not to show up to work sick. Hey, you can show up on Zoom instead. So these types of options that were kind of in the background before, but maybe if they become a little more mainstream, then we can see sustained low flu numbers, which would be great.
I know many businesses are considering not having people come in every day anymore.
That's right.
Yeah.
That's right.
Especially
you could cut your office real estate cost by having a smaller office.
You'd have to make it smaller. There's no point in keeping the big office and say, okay, everybody come in 2 days a week.
Right.
But that's a waste of money. You got to
you have an office half the size, and everybody comes in for part of the week.
Well, this is actually part of the motivation for Daniel and I to rent office studio space, because the costs have gone down substantially here in Manhattan. And we've talked to the owners of the building. By the way, we're signing the lease on Monday. And
cool.
we're talking. By the way, Brianne, on the live stream the other night, someone asked, "Will Brianne be a regular visitor?" I said, "I guess a couple times a year, probably." The realtor said, "We don't know if it's going to recover. We have no idea."
Right.
In fact, the whole garment district, we were originally looking at space there. There's very little garment making there anymore. They've all gone. And even the guy who owns the building we're leasing, he said, we have a lot of empty space. We don't know when, and people are leaving left and right. So we know all the spaces we saw, people had been in there. Their stuff was all there. And he said, yeah, they're moving out. I mean, the place we rented or leased was previously occupied by a company that sold airline tickets. He said they used to have a big safe where, remember, tickets used to be worth something for the airplanes, right? In the old days. He said they kept the ticket. He said they went out of business. Oh, boy. So I think you're right. I think we're going to change a lot of things. Science is going to change too. Meetings, are going to change. I don't know why I need to go to California to give a seminar, right?
Right. Well, didn't they change that already at NIH for study sections? So
is that permanent? What
took everybody so long?
Well, they needed a kick in the pants to get it done because it's different, and everybody thought, we've always done it in person. But this has so many ancillary benefits too. I mean,
I think so.
The carbon footprint of a big meeting. Yeah. So there was one during the pandemic. It was one of these big, I think it was like an astrophysics convention. They used to have thousands of people showing up to, and they calculated the difference in their carbon footprint because they're physicists and they could do this. Even when you account for all the electricity and the internet servers and everything, it was thousands of fold less CO2 emission because they're not having everybody fly to a central place. So, I mean, we'll still have in-person meetings for some things, but I don't know if we'll want to do that all the time.
No more snow days, though.
No more snow days. Yeah. Yeah.
That's too bad. No more snow.
Yeah. But do you think the restaurant industry will fully recover?
Gosh. So we just, by the way, Sophie just got her second Pfizer dose yesterday.
All right.
Yay.
So yeah, we're all fully vaxxed, the humans anyway, in this house. And just last
Cats
weekend,
can catch this too.
Just last weekend, we went out to a local restaurant that we'd been meaning to get to, and obviously hadn't been able to, and it was packed. It was because Massachusetts. That was Unmasking Day in Massachusetts was Saturday, or as Laura put it, Unmassachusetts.
Unmassachusetts. That's nice. I like that. That's a good one.
I've had several invitations to go to restaurants, and I've declined. I said, no, I'd like to wait till July or so. But one of our listeners from California is here in New York, and she is going to lunch on Thursday with Robert Fullylove. Remember him?
Oh, yeah, sure. I know him very well.
And she invited me to join them at a local
you should go.
place. You must know Malicone Dixon. Is that the name?
Oh, El Malicone?
Yeah.
They're still there?
I know where that is. Of course.
Right up Broadway.
I would walk past there. If I took Broadway home, I would walk past there and the smell.
It's a good place.
It's a good
place. It's a very good place.
Yeah. Oh, the window is full of this rotisserie
chicken.
Yes. And
if you walked up, you could feel the heat coming through. Yeah. Anyway, I'm trying to decide whether to go or not. I mean,
I would go if I were you.
I just probably know. I just haven't been in a closed restaurant.
You're vaccinated. You're vaccinated, Vincent. You're inert.
I am
Correct.
vaccinated. Yeah, I should be able to go.
I got to say,
Bulletproof.
it was weird. It was really weird, and I had forgotten some aspects of it. So that the waiter brought the check, and I was looking at it,
What's
and
this?
I thought, wait, where do I write the tip amount? There's no blank. There's normally a blank. And then Laura pointed out that's just the check. It's not the credit card receipt where you write the check. Right. This is a two-phase process. I totally forgot.
Two-phase process. All right.
Forgot how to interact with a restaurant.
One more paper. This one we'll get to talk about. RATG13.
Yes.
This is a pre-proof in Cell. It is called Binding and Molecular Basis of Bat Coronavirus, RATG13 virus to ACE2 in humans and other species, out of a number of groups in China, including second to last author is George Gao, last author Shihi Wang. And let's see, where are we from here? We've got to go down. Chinese Academy of Sciences, let's see, Beijing, Shanghai, Shenzhen, Hefei, lots of different places all across China. All right, so.
And I hope the title is going to get an edit because it's grammatically
It's a little weird. Yeah, I'm sure it will be.
But yeah.
But this is a pre-proof, so they haven't proofed it yet. Yeah.
So this is
Accepted, right?
Cell's effort to capture preprints. It's a pre-proof.
But it's been accepted.
But it's peer-reviewed.
It's peer-reviewed.
Yes.
Yeah, it's kind of in a weird limbo.
Right, so
Well, Alan may hope that the title gets changed. I hope that I guess it's the graphical abstract or the image that's at the beginning. I hope it does not get changed.
it's nice.
It's very nice in terms of sort of showing the take-home message of the paper, but also in some of the things they use to represent the different species.
Yes.
I really like that the person has a top hat.
Yes. It's very nice.
Yeah, it's very cute. This is a picture of what species can be. It will be the spike protein of RATG13, right? Which species it binds the ACE2 to, right?
Right.
And the cat looks like our other cat, Oliver. It's a cow cat. Very cute.
And they have a branch which has bats on it. And some of the bats are in the binding color and some of them are in the non-binding color. It's cute. So as everyone must know, many bats are the sources of many human coronaviruses. And the SARS-CoV-2 likely came from a bat somewhere. We have yet to pinpoint that. But SARS-CoV-1 came from a bat via a civet cat in a open meat market. And the closest bat coronavirus, SARS-CoV-2-like bat coronavirus from bats is RATG13.
Closest that we've found.
That we have found so far, yes. And we will find closer ones. We will find a 99.9% one, and that will ring the bell, but we haven't got it yet. But that was picked up. So that has 96.2 identity at the genome level with SARS-CoV-2 genome. That is the closest known SARS-CoV-2-like virus. And it was identified in 2013. That's where RATG13 comes from a Rhinolophus affinis, which is the intermediate horseshoe bat.
That's where the RA comes from. Intermediate horseshoe, yes.
Intermediate.
That's right.
And
it can hit the steak most of the time with.
Well, exactly. It's a leaner.
I think it's a funny name.
Yes.
And it was from a cave in Yunnan province, which is about 1,000 kilometers outside of Wuhan. So this, go ahead, Rich.
I want to point out up front, because I have to remind myself of this all the time, that the phylogeny here does not mean that SARS-CoV-2 evolved from this virus.
No, not at all.
It means that they had a common ancestor some time ago.
That's
and
right.
so what that means, importantly to think about, is that RATG13 could have been on its own pathway, diverging from the common ancestor separately from SARS-CoV-2. So it's not it's not as if this is the basis framework and we've evolved beyond that. There's two independent lineages with a common ancestor.
Right. Yeah, that's right.
We did not evolve from ring-tailed lemurs.
Right.
But we share a common ancestor.
No. Right. And my recollection is that the molecular clock analysis on this suggests that common ancestor was around on the order of 60 years ago. Am I remembering that correctly?
Yeah.
We're talking a few decades.
Yeah.
Okay.
And this whole lineage of SARS-CoV-2 like coronaviruses, completely unknown before SARS-CoV-2. It was unsampled. No one had ever picked one up. So people who think this came from a lab, no, it never came. No one ever had these viruses.
Nobody was even looking at them.
So RATG13, 96.2, that means there are about 1,200 base differences. So for those of you who think, yeah, they were working on RATG13 and somehow it became SARS-CoV, no, not possible.
It's a long way off.
Now, one of the things that RATG lacks that
I don't know about not possible, but it's really, really unlikely.
Yeah, not possible is a strong statement, but I'd like to make those these days because you need to counter these bozos who say dumb things.
But it could have happened, yeah.
It would take a long time. I think that the estimate is it would take about 10 years of circulation at the current rates of mutation to go from RATG13 to SARS-CoV-2. Anyway, the RATG13 was present as about a 30 base sequence in the database from 2013 to December 2019. And then when they blasted the SARS-CoV-2 sequence, they picked this up as the top hit, and then they did the rest of the genome. So nobody had that virus actually in the lab. And my understanding is Zhongli Shi cannot grow RATG13 in the laboratory. She's tried, cannot grow it.
For our listeners who don't know what blasting means.
Sorry.
It's the name of a database.
Yes, it's the name of a database. So basically sequences that have been found can be deposited in this database. And then investigators can put in a sequence and try to find other sequences that have a lot of similarity. Or identity usually.
You mean it's like an electronic PCR?
No, it's more of an electronic. All of the other things I was wanting to compare it to are also electronic.
All right, I'll take it back.
It's a database.
It's a database. The basic local alignment search tool.
So,
right.
I made a verb out of a noun, right? Yeah.
Yes.
Yes.
Yeah. You're not alone in that.
No, verbing is a very popular activity.
Right.
I often talk about blasting.
Yeah.
I often I let my colleagues here explain all the things I don't. They're good at picking that up. So one of the ways that RATG13 and SARS-CoV-2 is different in the furin cleavage site in the spike protein, right? Where SARS-CoV-2 has RRAR. The proline, by the way, is not part of the furin cleavage site, but the proline is also unique to SARS-CoV-2. It's not present in RATG13. So SARS-CoV-2 has PRRAR, of which RRAR is the furin cleavage site, and RATG13, as well as pangolin isolates, SARS-CoV-1, other SARS-CoV related viruses from bats have R. They're missing PRRA. Okay, that they do have that last R, and they have other. And I know this because I have a cheat sheet in front of me. I didn't memorize it. These days I have a lot of cheat sheets. Okay, so back to the paper. So that's why someone said that the furin cleavage site was a smoking gun because, hey, it's not in RATG13 and it's in SARS-CoV-2. But, that's meaningless because they're not ancestor product, as we just said, and other coronas do have furin cleavage sites.
And coronas recombine all the time.
Right. All right. So the basic tenet of this paper is, could RATG13 infect humans and other animals. All right? And we will not get an answer to that question because this paper focuses entirely on spike binding to ACE2. And that is not the whole story for any virus. Now, you may have thought otherwise, but I hate to disappoint you that just because a virus can bind a receptor doesn't mean it will infect that cell. We've gone over this a lot of times, TWiV, but knowing it can bind is a good first step, right? I have big arguments about this with Amy all the time because some people say, well, we're going to assess the pandemic potential by seeing if the spike binds to a receptor. And she goes crazy. She says, it only tells you it binds the receptor. It doesn't mean
doesn't mean anything.
I mean, I think anyway. So with that caveat, they're just looking at the interaction. I think it's reasonable to do that.
It is one of several relevant variables.
Exactly.
Yes. Okay.
And Amy told me this morning that youngly she has tried to propagate RATG13 in human cells, and she cannot grow it in human cells. Okay, so there are obviously other issues there. I mean, as was already known, RATG spike binds to ACE2, but with lower affinity than that of SARS-CoV-2. All right, so, but this beyond that, there are still blocks to reproduction.
Yeah, and those blocks are sometimes intracellular blocks.
That's right.
In a lot of different ways. But you can also think about some blocks that are related to that binding event, or some of the details of that binding event, like with flu and HA. If you just look at HA binding, that doesn't tell you the whole story because you need to also know if the NA can actually let the flu virus leave or whether the flu is going to stay bound to the cell.
That's right. Absolutely right.
And we don't even know what all the other blocks are.
We don't. We do not. This is the first. This is very easy. This is kind of like doing a new antibody neutralization assay versus a T cell assay. It's really easy. So you could look at binding and you do it.
My understanding is that one of the most important new observations out of this is an actual atomic structure of the RATG spike protein with various ACE2 receptors.
That's right.
Yes.
That's right. So let's get into the data here. So first, they're focusing on the receptor binding domain, which is a small part of spike that binds ACE2. It's its own domain, and it binds to ACE2. And if you look at the sequence, this is very interesting. The receptor binding domains of RATG13 and SARS-CoV-2, 89% amino acid identity. But if you look at the interaction of the two, the RATG SARS-CoV-2 RBD with ACE2, of human ACE2, there's much less contact of the RATG RBD than there is of SARS-CoV-2. So that should tell you right away they don't bind as well. And in fact, they did affinity measurements, and the binding affinity of the RATG RBD to ACE is 100-fold lower than that of SARS-CoV-2, which is quite a bit. So now they do some infectivity experiments. They make VSV with the spike protein of either RATG13 or SARS-CoV-2. And this VSV has green fluorescent protein in it so that the cells become green if they've been infected. If the virus actually gets in and begins to be, mRNAs begin to be made and protein begins to be
So
made.
VSV is vesicular stomatitis virus, another single-stranded RNA envelope virus, different family, even very different, but real easy to pseudotype, that is, get new novel envelope proteins in. So it's used for this kind of, and easy to work with. So it's used for this kind of thing frequently.
So this takes all of those issues that Brianne was mentioning, the internal cellular issues that might come up, whatever else, and forgets about them. Says, okay, let's just make VSV use the receptor binding domain of RATG13 and see if it can get into the cell.
Yes. So all you're looking at is binding and delivery of the genome. Everything beyond that is VSV. So all you're asking is, can this spike protein mediate entry of a VSV into cells? And the answer is yes, it can do so. They use HeLa cells that produce human ACE2. But the SARS-CoV-2 spike is way better, way more efficient than that of RATG13. But it gets in. It's not zero. As Daniel would say, it's low, but it's not zero.
It's not zero.
I really like that. I really like the way he says that. Okay, so why is that? They did structures now. They produce the proteins. They produce the RATG13 receptor binding domain. They put it together with ACE2, and they study the structure. They make crystals, and they do the structure at low resolution. And now they can see which amino acids are contacting which. And I'm not going to make you go through all the details here, but suffice it to say that there are more contacts between the RBD of SARS-CoV-2 and ACE2 than there are between RATG receptor binding.
The binding data makes sense in terms of the structure.
Yeah, and presumably that entry data of the pseudotype also is a reflection of the low affinity of the two, right?
The SARS-CoV-2 domain fits better.
It fits better. It fits better. And then they can, so they can actually narrow the difference to the number of amino acids, and they can actually do an experiment to test that. But first, let's see, did they do that first? No. First, they say what other ACEs from what other animals, ACE2, will bind the RBD of RATG13. And so they actually produce ACE2 from a variety of animals, non-humans, and they look at binding to the RBD of either RATG13 or SARS-CoV-2. And so this is a lovely zoo.
I love this. There's 25 different critters.
Yep.
25 different critters. The RATG13 RBD can interact with primate, lagomorpha, rabbit,
right?
Carnivores, that's cat, fox, dogs, and raccoon dogs, horses.
Uh-huh.
And I'm just thinking of all those names for animals that we went through on TWiV. Pigs, camels, bovines, goats, sheep.
Bovines being cattle, not cows. Not just cows.
Right. Exactly.
And not just heifers either.
And not just cattle, actually.
Or steer
bovines
or gomers. You know what a gomer is?
Yeah.
You do it, Dixon?
I do.
They leave behind a pile. No?
They do. They are the pile.
Oh.
The gomer is an animal that's about to die, I believe.
No, a gomer
that's a goner.
I think if I remember. No, I'm not going to even say it because I'll forget it. I'll get it wrong. Anyway.
All right. I don't know what a gomer is.
So the SARS-CoV-2 RBD also bound to these ACE2s, but better than RATG13. And also, SARS-CoV-2 interacts with Malayan pangolin, alpaca, intermediate horseshoe bat. That's good because that's where it came from, right?
Yeah.
And the big-eared horseshoe bat. RBD does not. How is that possible? How does RBD not interact with intermediate horseshoe bat or ACE2? Because that's where they...
Maybe it needs more of the spike. Here they're just transplanting RBD. And so maybe it's, say, folding slightly differently when they just use RBD rather than full spike.
They didn't even make a remark on that. Anyway.
That is an interesting point, though, because it highlights a limitation of this approach, a major limitation, which is your assay is not detecting the interaction that obviously must occur in nature, right?
The assay brand is by flow cytometry, so maybe it's just not sensitive.
They have if you look at part B of the same figure, they're assaying it by, what do they call it? I'm thinking biochip. I'm blanking. Biacore. Okay. And, or something equivalent that gives them more precise, that gives them actual KDs.
Yeah.
And under those circumstances, you can see the binding to the intermediate horseshoe bat, but not the little brown bat, not the least horseshoe bat, not the big-eared horseshoe bat, not the pangolin, not the civet, but some sort of binding to all the other species.
That's right. That's the limitation of the assay. Good.
Also,
Excellent.
Not the lesser hedgehog tenrec. And I have no idea what tenrec means.
You don't.
We'll look up at the graphic abstract. What I'm really impressed with, out of the first part of this, the flow cytometry, is how well the SARS-CoV-2 spike binds to a large variety of receptors.
It does. It does. I think these ACEs are quite conserved too, right? They must be.
Tenrecs appear to be endemic to Madagascar.
Really?
Yeah, they're...
What are they?
They I guess one of them got there and they radiated into a whole bunch of species for different environments.
Do they fly? Do they walk?
No, they're little shrew-like things.
Shrew-likes, okay. Okay.
Actually, I don't know how little they are. I'm not seeing a scale.
So now it turns out that there are 6 amino acids that they think are crucial for the difference in binding between the SARS-CoV-2 and RATG RBD. So they change those either one by one or all 6 together. All right. So they take RATG RBD and they change it to be SARS-CoV-2 in these 6 positions. And when you do that, if you do all 6, basically you can improve the binding of the RATG RBD to human ACE2. Remember, it's not very good to begin with. This makes it better. Not as good as SARS-CoV-2 still,
right?
Because there are probably other amino acids that are important too. But it gets better, and it helps the pseudovirus infect a little better as well. Although, we're looking at number of green cells in a field there, and that's not very satisfying to me in terms of quantification. But I don't think they ever did binding affinity of these, did they? Don't remember that they did that. Anyway, so there are a limited number of amino acids that control this affinity. And they go on to look at some of these other species. And it turns out that amino acid 501 is important for the host range. That is the ability of the RBD to bind other species, in particular mice. So what is it that SARS-CoV-2 doesn't bind mouse ACE2, but if you change 501, it will, and that was done by a number of groups. And it turns out that the RATG13 has the right amino acid there to bound mouse ACE2. So it's already able to. So wonder what the ancestor was able to do of both of them. We don't know.
Yeah, so they looked at binding affinity somewhere here because they found
those
horse
6 amino acid.
Yeah, horse had the highest binding affinity.
Oh, that's right. The horse, that was the other take-home message, is that horse ACE2 has a very high binding affinity for RATG13 RBD, right?
Right.
Yes. So, should a horse encounter an intermediate horseshoe bat, might be infected. And I think in some parts of the world that those encounters might happen, right?
Sure. I still just, am very impressed by how much this shows that really strong binding isn't necessarily needed in the intermediate host or in a host.
I agree.
And
I
so,
totally agree.
Sometimes what people will say, well, no, there's not strong enough binding. This virus couldn't have been in this location. And here we can really see that, look, there's not particularly strong binding. There isn't this standout of intermediate horseshoe bat ACE2 binding.
Right.
It's actually one of the weaker ones.
Yeah, so if you went with just the binding data, you'd say, oh, this is a horse virus.
Yeah.
Well, no, it's found
and
in a
that's
bat.
why when you see variants that have changes in the RBD and you say, oh, they improve the affinity of the virus for ACE2, so what? It may not make any difference in infectivity, right?
It could actually be bad.
Could be bad.
If it sticks too hard, then you can't come off, and that causes a problem.
And finally, they look at binding and neutralization by sera from patients. So they have 6 convalescent donor sera, and it turns out these can recognize the RBD of RATG13 a little less well than the RBD of SARS-CoV-2, but they can bind it. So these people recovered from SARS-CoV-2, not RATG13 infection, SARS-CoV-2, and their sera can recognize the RBD, and they can neutralize the pseudovirus, which has VSV with the RATG13 spike, which is and the thing is that it's actually the sera are better at neutralizing the RATG13 pseudovirus than the SARS-CoV-2 spike pseudovirus, and they think that might be because the SARS-CoV-2 pseudovirus binds too tightly, and if these antibodies are blocking attachment, they have a better chance of blocking attachment of RATG13 pseudovirus.
So if you're immune to SARS-CoV-2, you might be cross-immune to RATG13 should it ever come up. But since it apparently can't even be cultured in human cells, it's not even clear that it can infect humans.
And they also looked at some of the monoclonals, the commercial monoclonals that are used for therapeutic purposes, Regeneron and others, and they find one called CB6 that can neutralize pretty well the pseudovirus, though. So I guess these antibodies are blocking attachment. So this bottom line here is that this RBD can bind ACE2 from a variety of species. There's an amino acid that's important for infecting mice. The horse affinity is high, but they say no evidence indicating the susceptibility of horse to SARS-CoV-2. Nobody's looked at that.
Right. So horse affinity is high for both RATG13 and SARS-CoV-2. Their previous work had found SARS-CoV-2 high affinity for horse.
The intermediate horseshoe bat weakly binds RATG RBD. Similar phenomenon is observed in other coronas, including SARS-CoV. So they do remark on that. It's a weak binder, but it can still infect.
So this is the kind of thing that needs to be done with not only this, but other viruses yet to be discovered out there in the biosphere. Not only this kind of assay, but assays looking for all of the other factors that restrict spillover and might be implicated in spillover, so that we can understand how spillover happens. And one of the things that I think of is that if you describe these experiments without any context, it sounds like people are making monsters, okay?
Right.
But in fact, what people are trying to do is understand the barriers to spillover and the mechanisms of spillover and what's out there in the biosphere to help anticipate this kind of thing in the future and guard against it.
And this is the kind of thing you do stepwise. So as a first step, what cells can you culture the virus on? And you obviously do that under very careful containment conditions because you don't know what can get into humans or not. But then after that, you say, okay, what can stick to what? And with that, you can do these pseudotyped experiments. In fact, you probably want to, because then you can bypass internal steps and just look what binds. And then, okay, here's stuff, because that, even though it's not sufficient for complete infection, it is necessary. Right. And then you can go and probably simultaneously look at other steps in the infectious process. Can we get, if we get past the binding step, can we get to making viral proteins, et cetera, et cetera?
I would actually do those in the opposite order, Alan. I would want to, instead of just putting them on all the different cell types first, I'd say, well, which ones can it stick to?
Right.
And eliminate from there.
Yeah.
Well, this paper does not say that RATG13 is a threat to humans.
No,
because it can bind, which is a good step. If it didn't bind at all, then I would say, don't worry about it. Although maybe it only takes one amino acid to change and then it binds, right? So it's a tough question. But the real question is, does the viral genome reproduce in human cells? And that's not addressed in this paper. It's not just about the receptor. And as I said, according to Amy, Zhongli says it does not reproduce in human cells in the laboratory. So there's an internal block of some kind, which is good.
Yes.
I would like to have the ancestor of both RATG and SARS-CoV-2 and look at that and see what that's doing. Because maybe it had a furin cleavage site and it got lost in RATG13 and it was maintained. And you know what's interesting? The pangolin isolates do not have the furin cleavage site, but they have a better RBD binder than does RATG13. So there's a lot of convergent evolution happening. And at the level of ACE2 binding, I think there's a lot of similar ACE2 out there.
And I think we should be interested not just in what infects humans, but in what can spill over into peridomestic animals and food animals.
Yeah.
Because, I mean, the SARS lesson there is anything that's going to be near humans or farmed by humans or eaten by humans is a potential intermediate host for any of these things.
This paper contains a lot of information about the binding interactions and what's important in determining the binding of a spike protein to a bunch of different species in contrast to SARS-CoV-2, so that when you come up with a new spike from some other creature, from some other virus or something like that, you have a lot of background. You know what you're looking at.
Yeah.
Yeah, I mean, you could say, right, this spike didn't bind to these species, so they're probably not a priority to look at in terms of infection. But the other horse, you might want to look to see if it gets infected with these bat SARS-CoV-2 viruses.
And as they comment, I wasn't aware of this, but apparently beta coronaviruses are very widespread in horses.
I saw that, yeah.
And so if there are a bunch of other beta coronaviruses in horses and this thing can get in and maybe other things can get in, that then the horse might actually be a place where you're getting these kinds of recombination events going on.
You know, a horse walks into a bar, the bartender says, "Why the long face?"
You stole my joke.
The horse said, I have these beta coronaviruses that are driving me crazy.
That's the tagline.
No, I know the tagline. There isn't one, actually.
No, there isn't one.
Okay, let's do some picks of the week. Dixon,
all right.
What have we?
I have to scroll down to remind myself now. But my pick of the week is a NASA pick, Richard, just for you and me, or everybody else that wants to join in, of course. The Juno satellite that's surveying Jupiter right now is going to have a very close look at Ganymede. Now, Ganymede, that's probably not on the top of your list for things to look at, but and NASA's list didn't have that either until they realized that they could get within 600 miles of this planet. And I say planet because it's bigger than Mercury. This moon around Jupiter is bigger than Mercury, which is a planet. So why don't they consider Ganymede?
It's orbiting another planet, so it can't be a planet.
Well, you could call it Planet 2 or something. You're calling it Beta.
Like the difference between
it's a beta planet.
I mean,
well, the point is that they're going to get amazing data from this. They've had Voyager 1 and Voyager 2 go past, and they've both taken photographs of this mysterious ball of rock and gas. It's got a little gas, but it's got more ice than anything else, right? It's a solid ball. It's not a gas planet or gas planetesimal. So it's going to happen on June 7th.
Very cool.
Neat.
So if you
like this.
If you search the webs, why isn't the moon a planet? There are lots of posts, including one at NASA, and they explain why like our moon has a lot of properties of planets, but it's not a planet. It's a moon.
I mean, why isn't Pluto a planet? Well, we don't go there either. But.
And I have to just say, as an aside for the sci-fi people out there, that Ganymede pings my radar because in the Expanse sci-fi series, Ganymede is the farm planet or the farm moon for the outer planets and Mars.
It's a moon. It's a moon in the show.
It's a moon. Yeah. In the show, it's a moon.
You know, I have trouble with variants in planets. Can't remember what's what, especially moons. You know, all those moons of Jupiter. Can you name any others, Dixon, besides Ganymede?
Yeah, Io. Europa.
Attempt no landings there.
No, do not go there. That's right.
Why is it all gas or something?
That's the punchline of 2001.
It's 2001. That's right. That's right.
All of these worlds are yours except Europa.
And the rest of them I block on. But those are the ones that are famous. The one Io has volcanic eruptions regularly of sulfur, and it's so close to Jupiter that it's heated up by gravity. And as it goes in an elliptical orbit, it loses that elasticity, and then it gains it again. And when it gets closer, it throws out all these fumaroles of liquid sulfur. That's as foreign as it can get, folks.
I have one more planetary question, Dixon. Does every planet in our solar system have a moon, at least one?
No.
Which does not?
Venus
I don't know the answer.
Venus doesn't have a moon.
Does Mars have a moon?
Mars has two moons, Phobos and Deimos.
Oh, Phobos, of course, right.
Jeez,
And
Dixon,
what about
you're really hot.
what
I
about
don't know.
Mercury?
Excuse me.
What about
Mercury
Mercury?
doesn't have a moon either, but Mercury's smaller than Ganymede. I would consider that the sun's moon.
Well, that's a planet.
We're all the sun's moon.
That's right. That's right.
Oh, cool stuff. I love what I don't know. It's just great. Brianne, what do you have for us?
So I have an article called "Send in the Bugs: The Michelangelos Need Cleaning," and it is a story about a chapel in Florence that had, since 1500 something, had all sorts of different debris and actually decay. Apparently, some people were buried without being embalmed there, and
Oh my!
all sorts of different things that were making the statues and making these beautiful Michelangelos really difficult to see. And so they actually started doing restoration by inoculating bacteria that could degrade the contaminants, but couldn't degrade some of the art. They started this before COVID, and then when the chapel was shut down for COVID, they did a much larger experiment. So they basically first did some chemistry to figure out what was contaminating parts of the, for example, the statues. And then they went to the lab and looked at a whole bunch of different strains to see which bacterial strains could actually metabolize those things, but not marble.
Right.
And then they went into a back corner of the altar and made a grid of different squares and tested a bunch of the different organisms to see which ones actually could clean off the grime. And then use mostly a Serratia strain and a Pseudomonas strain to clean the statue, these Michelangelo statues in this chapel. And I just think it's really fascinating and
cool.
a pretty cool way to think about.
So did the bacteria, once they finish their job, leave a biofilm?
They don't mention one, no, but I don't know.
But, you're just trading one piece of dirt for another, it sounds like to me.
But if you're trading it for dirt you can't see, then
Right.
who cares?
Yeah, well, that's also true.
I guess you have to have some
true.
confidence that it's not going to completely destroy the statue, right?
Yeah, so
No,
they mentioned
no.
that they had a meeting with some of the people who were in charge of the chapel, and they talked about this work being done in past places. And like I said, they did some experiments in a sort of hidden place
Cool.
to see what would happen. I just thought that was really cool.
It's very cool.
Oh, yeah,
Really
absolutely.
This is great.
Has everybody seen the Michelangelos in Italy?
Yeah.
Oh yeah,
I've seen them.
I've been to this chapel.
Yeah.
Yeah,
I recognize the dawn and dusk tomb sculpture.
You got to go to Florence to see the David, though. It's so cool.
It's fabulous. It is
just amazing,
absolutely. It's stunning. Stunning.
So this is bioremediation, right?
It is. And they said that some of the
Bioremediation.
strains were found in areas that were contaminated with other things like heavy
Nice.
metals.
That's great.
But then also they realized they could be used in this way.
I'm
Very
sure
cool.
they're going to. I'm sure they're going to publish this. We'll have to do that on TWiV. Nice.
Yeah.
Rich, what do you have for us?
This is just a little ditty that I ran across on Facebook, and I couldn't find an original reference to it, so it'll be the Facebook thing. I like on Facebook a page or a site that's about the Perseverance rover, and if you scroll down on this, there's an animation that I think originated from China that shows a chronological sequence of all of the different landers that have landed on Mars with a little annotation on them and what they do and when they were. And one of the amusing things about it is that they've animated in a human that walks from one to the other so that you can see the relative size of the landers and relative to a human. And you can see how they get bigger and bigger. So I thought that was kind of amusing, at least.
Yeah.
Neat.
Very cool.
Alan, what do you have for us?
I have, so this is a morbidity and mortality weekly report paper. It's from a little while ago. It's about a case cluster, 5 guys who showed up with an unusual pneumonia in Los Angeles.
Los Angeles.
And, it's one of these case clusters. It's probably nothing significant, but
No.
caught my attention.
They called it pneumocystis, as I recall.
Yes, so the pneumocystis pneumonia in Los Angeles in 5 young men.
That's right.
And this paper came out tomorrow. In addition to being Dixon's birthday, is the 40th anniversary of the publication of this paper.
How cool! How cool!
And the significance of this is in the second link in my pick. So this is estimated annual number of HIV infections in the United States from 1981 to 2019. Those 5 guys had AIDS. They were the first reported human cases of it. And so then this is how the pandemic has gone in this country since, which is actually kind of a bright spot because you see the curve going way, way down as we figure out what's going on and we stop spread, and then we come up with antiretrovirals, and the whole pandemic process plays out. Of course, it took quite a while for all that to happen. But now as we come to what is probably the end phase of another pandemic and people are talking about the new normal, seems like an appropriate time to think about how the world changed in response to this pandemic.
Indeed.
And I think it's also important for people to realize, the COVID-19 pandemic isn't the first pandemic that many of us have seen during our life. Because we've all been living through this pandemic.
All true. All true.
Oh, by the way, I forgot to point out in the introduction to one of the papers today, I forgot the exact wording, but they say that the SARS-CoV-2 is the first coronavirus pandemic. Okay, so it's those of you who think SARS-1 was a pandemic, it never was, but some people think it is. And you can find references online by reputable people who say it was, but it was not. It was 8,000 cases.
It was never reached the scale for WHO to declare it a pandemic.
So there are 34,800 cases in the U.S. in HIV/AIDS in 2019. So it's not insignificant still.
No, absolutely not.
But it is, importantly, it's manageable.
It is manageable.
And that has gone.
As long as you can afford it.
Yes. But the fact that has gone from being a death sentence to being a completely manageable condition.
That's right.
And the people who are on antiretroviral therapy get down to undetectable viral levels, so they can stop the spread.
It's manageable, but it's still not something you want.
Oh, it's definitely not something you want. No.
Changes your life.
It should not be a question of affording. It should be available to everyone. And the fact that cannot afford anything in this country is, I think, unacceptable.
So what do you think about the giveaway for the vaccine now, Vincent? You must have a brighter look on that at least.
It's fine that they encourage
100 million doses they're going to give away.
Yeah, I think that's great, but it's still, we need more. We need to
it's
do more.
Probably a little late in the game to be doing
It's going to COVAX, right?
Yes.
80% of it is going to COVAX. Another 15-20% or something like that is going to targeted countries of one sort.
Guatemala is on that list.
Yeah. Very good.
I have a couple. Alan, this is great. I have a couple of comments. If you look at this graph that they have at the end of this article, this is terrific. I once heard a talk from a physician in LA who was an ID doc when this was going on, and she showed the first part of this graph. Okay, and she said, I was on the wards between 1981 and past 1986, and points out that in 1983, 1984, we were looking at the front end of this curve, and it was going through the roof with no end in sight, and all the beds were filled with AIDS patients, and it was terrifying. We had no idea what was going to happen. And then this decline is antivirals, which is just it's a triumph. It's not a miracle. It's a triumph. Okay. The other thing I want to point out is that, to quote a clinical friend of ours, it's not zero.
It's not zero.
All right. Yes. In 2019, there's 34,800 cases in the U.S.
Yeah, that's just
this decline is initially non-pharmaceutical interventions.
Yeah.
Which were highly effective within limits, but then the real sustained decline, and especially if you look at the curve of deaths. But this was a transformative event for an entire generation of researchers and physicians. And in fact, when Tony Fauci was on the show, I think it was the first time he was on the show, He talked about that and his experience of this and how it helped direct the course of his career.
Yes.
I mean, I think that also it's not just transformative for researchers and physicians. I think it's also transformative for just a lot of people in general.
For society.
Yes, for society, and part of this might just be because I, in the past few years, have taught a seminar to first-year students on HIV. And so I get to see what 18-year-olds think about it compared to, me who was alive during those years of the 80s, because they don't know. And they didn't go through kind of some of that on the news all the time and being scared.
One of the major pathologists at Columbia who used to do a lot of teaching had AIDS, and we watched him deteriorate right before our very eyes. And it was the saddest thing I've ever seen in my life. To go from a vibrant, alive, remarkable person to basically a zombie that was just coming into work and not knowing what to do and not even being able to find his way to his office. It was just horrible, absolutely horrible.
I often use the emergence of AIDS when people say to me, hey, isn't it coincidence that, the SARS-CoV-2 emerged in Wuhan, and that's where they were working on coronaviruses? I say, really? Did you know that HIV/AIDS was first noted in Los Angeles, but it really emerged in Africa in 1920?
Right.
So what? And then he goes, then the retort is typically, why are you defending China? I'm not defending. I'm telling you the facts. These are the facts.
Right.
Where you first detect a disease doesn't mean it started there.
That's true.
Okay. My pick is a video I made a couple of months ago. I thought I had picked it. I don't think I did, but it doesn't hurt picking it twice. It's a short video I made on virus, isolates, strains, and variants. What are they? Just tell people what these things are. And it's based on, it's not my opinion. It's
just definitions.
It's definitions. Yeah. And I use some quotes from Jens Kuhn, who's always quotable.
Nice.
And one of the best quotes is from a paper he wrote about this. Actually, it was the designation of a strain is the job of a international committee of experts, which I love. And I say, well,
that's good.
And I say, which means it will take some time.
Yes,
exactly.
To do that. Okay. That is TWiV 765. Show notes, microbe.tv/TWiV. Dixon, what's going on outside?
You tell me. You can see. I can't.
Is it pouring out there, Brianna?
I can't see outside. That's what's going on. It's absolutely, the heavens have parted, and we should start building an ark.
Yeah, no, it's
immediately.
Loud,
this is
thunder and lightning. Actually, when my motion sensor.
I did see that. I did see that.
My light turned off because I wasn't moving around enough in my office.
Cool.
And for a second, I wondered if the power was going out.
Vincent, look for the. Tell me if there's a funnel cloud heading my way, would you please?
It'll pass. It'll pass. Microbe.tv/TWiV for the show notes. If you want to send us questions or comments, TWiV@microbe.tv. If you like what we do, consider supporting us. Microbe.tv/contribute. Dixon Despommier is over at Racaniello.org, thelivingriver.com. Thank you, Dixon.
You're welcome. This was a great time. I'm sorry I didn't have more to say, but I didn't know enough to say anything. I learned a lot.
No need. You learned. That's good.
I did.
Did you turn the light out? All of a sudden, it's dark.
I didn't, but I think a higher power turned the light off.
I see. Oh, do you hear the rain? Can you hear it?
I hear the rain. I hear sirens. I hear all sorts of
sirens going off.
The light on my face now is all due to my computer screen. That's right.
Yeah, you look very dramatic, Dixon.
There goes a bolt of lightning right next to us.
Brianne Barker's at Drew University, BioProf Barker on Twitter. Thanks, Brianne.
Thanks. It was great to be here.
Rich Condit is an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure enough, always a good time.
I don't think you have rain there, do you, Rich?
No. It's
coming your way.
Quite mild here.
Alan Dove's at alandove.com. Alan Dove on Twitter. Thanks, Alan.
Thank you. It's always a pleasure.
Any rain there, Alan?
No, not at the moment. Not that I can hear anyway.
It's cool. Me, Dixon. Well, we're just across the river, but Brianne, you're what,
Yeah.
45, 50 miles away probably, right?
Yeah, not quite that far.
And you got the same storm. It'll pass. I'm Vincent
They're
Racaniello.
dramatic.
What's that, Dixon?
No, I say they're dramatic. That's all. You and I used to sit in your office window and look at these things come in, and it was quite amazing, actually. Good stuff. Sorry, I didn't mean to interrupt you.
No, it's no problem. I can edit it. I'm Vincent Racaniello. You can find me at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.